my disclosures. These are all the various points that we're going to be considering. We have limited time, so we want quick, short answers. No repetitions, please. I'll try and get through this. So let me look at the first issue. A patient with multiple incisions. We have two scenarios. Amar, a patient who has multiple incisions and has good movements. Any thoughts around that? How would you address this? Let's take the slide on your left.
Yeah, I mean, we're classically told to use the most lateral incision. But 9 times out of 10, these incisions were done 10 years or more ago. And so most of the time, I will choose the medial incision. And I've not personally had a problem doing that. So I don't believe that teaching of using the most lateral incision is appropriate unless it was a very recent incision.
Right. Anyone in the panel disagrees with that or has a different point of view? Is Dan here? We need Dan on the panel as well.
If it is a older scar, 10 to 15 years old, I don't care. But if it is a recent one, I still choose the lateral most incision.
Okay. Would your approach be different, Rajesh, if this knee was multiply scarred and it was stiff?
Yes, I think, and what you mean is that not only the knee is stiff, but the skin over the knee is also not mobile.
Yep.
That's what would worry me, and
Yep.
I would definitely involve plastic surgeon at that stage.
Okay.
It also again boils down to how long back the incision was. That is the key thing. If it is a recent one, that worries me most. If it was few years, then it worries me less.
So Nandu, would you consider tissue expanders? Would you do it? Would you have your plastic colleagues step in? How would you do that?
I think expanders is a great idea, provided you select the right patient. I think it's plastic surgeons who generally perform it. In a multiply operated in arthroplasty after tumors, I think it's something which is very useful on a day. It can create a good pouch,
Okay.
a good medial base flap,
All right.
and lateral most incision can be accessed by around 25, 30, whatever degree of recommendations.
Okay. Anybody in the panel have experience of doing what John Insel described as a sham incision? No one. Okay.
Sir, only if the patient had a previous pedicle flap, sometimes, if the planned incision is away from the margin of the pedicle flap, once you had tried with the sham incision.
Okay, so you would consider that?
Ashok,
Yeah.
many a times you think that the tissue expanders will be required, and you speak to a plastic surgeon and they would rather say that at the time of surgery, I'll come and little rotate a flap.
Right.
So many a times they don't want to use a expander if they can do something else at the time of surgery.
That's exactly right. Tissue expanders have really sort of gone out of fashion now, and most times they will work around flaps and so on and be able to
So
get...
can puckered scars which are puckered and dimpled, is very useful.
Okay. Right, so in stiff incisions, stiff knees, these are the various options available. If you had a stiff knee, multiply scarred knee, you've done your incision, which of these would your exposure be? Starting with Amar? Just choose one out of these.
Yeah, I do a rectus snip routinely.
Rectus snip?
Rectus snip, in the past I used to do VY, and you don't need it when you do rectus snip, it actually opens up.
Rectus snip little further than the tendinous part of the tendon ends.
Gautam?
Rectus snip, but at the end, after the surgery, if the range of motion is less, I would later convert it into a PY.
Narendra?
Only experience I have is rectus snip.
Mahesh?
Majority of the cases, rectus snip is good enough only for cases which are stiff in extension that you might have to consider tuberculosis.
The only point I want to make is I'll have a lot of fellows and residents, they'll go up too high. So they'll make a very long extent, and then you can't do a snip in the muscle.
Yeah.
You got to do a snip in the tendon, right?
Yes, that was the next point. So what is the site of your snip? How far up do you go, Rajesh?
So I think it'll depend on the patient's quadriceps tendon. I look at it, how far, you have all different types. Someone with a very short
So
quadriceps.
is there a landmark that you have that
I want to go at least 2 inches above, if it is possible.
anyone do
Roughly.
anything differently? 2 inches, 1.5 inches, anyone else? Anyone do anything differently?
I mean, I
Right.
think that the take-home message that I want is you want tendon to tendon healing.
Yeah,
Right? You don't want
absolutely.
muscle to muscle healing.
Right. So these are just some of the references that would, some of these very historical turndowns that were described, and there's a very nice article in BJJ in 2015 that alludes to this. Just as a point of contention, rectus snip versus TTO, some of the recent articles have actually alluded to this. They've actually recommended a TTO as a better option, but I think, as you heard, most of the panelists prefer to do a rectus snip. Right, we move on to the next
Can
post-traumatic.
I go back though? And,
Yeah.
a well-performed TTO probably does better than, a snip in a very stiff knee. However, if you get a complication from a TTO,
The results are pretty bad.
That's very bad.
Yeah.
And you don't get complications from a snip.
Yeah. Your post-operative protocol remains exactly the same. Yeah. Right, so we come to the post-traumatic arthritis, managing implants, evaluating implant stability. So let's go down the panel. Dr. Reddy, you have this issue. How do you plan your post-traumatic arthritis?
The
Very
main-
short answers, very quick answers. Yeah.
Straightforward, I rule out infection or not.
Okay.
That's the first point. Otherwise, straightforward, remove the implants and go ahead with the total.
One
replace.
stage, two stage. Do you have preferences?
Most of the times go with one stage.
Okay. Mahesh, anything you do differently?
I mean, if the ESR and CRP are normal, no infection, you could consider it doing in a one stage, but I prefer to do a two-stage procedure for implant removal and TKR.
Okay, so what Jayant, what kind of problems do you anticipate in these patients?
So I think it's generally the question would be, should we retain the implants or are they going to come in the way? That's what something needs to be assessed. Stiffness associated, soft tissue contractures due to trauma, petla baha. So these are the things which would be important in this particular case.
Do you arrange for any special implants in case? Let's say, take this particular patient. Would you keep something that you don't keep ordinarily?
I think for the femur, most likely a PS. I'll probably keep a LCCK type of an implant, a slightly more constrained implant.
Okay.
But just in case, yeah.
And what do, Nandu, what do you tell your patients? So what kind of results would you like to tell them?
Concerns can be infection. The high chances post-op, it can land up in an infection which was not there before.
Okay.
Smear while you open the patient is important.
Smear for?
Smear to pick up whether you have polymorph count going beyond certain limit. There are markers which have been put
Okay.
by the infectious society.
Rajesh,
PGI Infectious Society.
would you add to that?
Are you talking about this patient?
Yeah, let's take this for
So this is non-union to me.
yeah.
And so I think I would, and also I would be worried about infection in this patient.
Okay, we have talked
Sen-
about that.
Yeah, the implant wise, I would keep sleeves ready because I think I might be able to get away using a sleeve and a stem on this with the
Okay.
non-union itself.
Right. So if you look at the epidemiology, it accounts for 10%. Risks of complications in this cohort is extremely high. These are the various issues, the bony issues, the soft issues, the contractures, the retained implant, risk of infection. I think you've all alluded to that. So let's take this for example. This patient had arthritis. So Amar, very quick, what would you do? One stage, two stage? What would be your choice of implants?
My choice would probably be to take it all out in a first stage. The patient has to agree to that, and the problem is the lateral plate. The medial plate you can deal with in the time of surgery. The lateral plate's challenging. So one of the decision-making points is: do I take out all the hardware or selective hardware? If the patient elected to do it in one stage, I would take out the medial hardware, and I would leave the lateral plate and probably take out just some proximal screws using some small pinhole incisions.
Okay. Mahesh, anything specific you have in terms of the implants?
For the implant removal, you mean?
Yeah, would you do this in one stage, two stage?
I would definitely do it in 2 stage. It depends on what approach has been used previously. And also you probably need to have the broken screw removal kit, and sometimes I rely on my trauma colleague to remove that plate for me.
So that's exactly what we did. We did this in a 2 stage. This is the post-operative X-ray, fairly uneventful.
Ashok, can I ask you something?
Yeah.
Where you've used a long stem with a cement, is that correct or?
No, that's not cement, no. We've used a hybrid fixation there because there was a considerable amount of bone loss. So these are very, very old. We didn't have access to sleeves and cones at that point of time.
And amazing that you've not had a cement extrusion from any of the screw holes. With so many screw holes were there.
We
Did
actually
you do anything special there?
Yeah, we plugged it with bone debris. Yeah. So the outcomes, as I said, results of post-traumatic arthritis is not particularly good. Lots of complications, worse outcomes when there are both defects on the femur and the tibial side. And again, the common denominator is outcomes are poor, risks of complications, infection, and stiffness. And these are some of the more recent articles, including one from the Dutch registry. In terms of stress fractures, let's start from the far end. Narendra, very quick, how would you address this? What investigations would you do? Blood work, radiology, anything?
At this stage, once a patient presents like this, even if you get vitamin D deficiency also, I'm not bothered about this at this point of time. I'll go ahead with the surgery and supplement post-operatively with whatever deficiency is.
Mahesh, would you fix the fracture first and then address it, or would you do everything together?
No, this is everything together job. This is a mechanical failure, stress fracture of proximal tibia, intramedullary instrumentation for the tibial cut using a stem.
Would you consider using some sort of a technology here, Rajesh?
Yes, I would. And I think the non-unions are not a problem.
All right.
It's the mal-unions which are the problem.
Okay.
But in both, I would use technology to get my...
So this is really what was done. Dan, would you agree with this? Would this be acceptable for you?
Apologies, I came in a minute late, so I didn't get to see the very start of the case. So I don't want to take you back through it.
No, so this was the preoperative patient, preoperative X-ray, and this is really what was done. Your comments on this?
Yeah, I mean, this is one way of approaching the problem. The other way of approaching the problem would be to use an intramedullary approach and fix the entire thing from the intramedullary side without putting a plate on there.
Yeah.
Probably I'd prefer the former rather than the latter, but you know, there's different ways to do it.
Yeah, so this patient actually, you're exactly right, it collapsed into varus, had subluxation dislocation. This is a PS implant, and this is really how we addressed it. With a revision system. A maluniting, ununited, again, stress fracture. Again, I'm not going to dwell on this. We used a long stem, exactly what you said, Dan. Bone grafted this with the material that we had. High tibial osteotomy, that went terribly wrong, again with the same type of an option.
Ashok, can I just, I will say though, having come to India for several years now, the incidence of this problem in India is much, much higher than, in North America and in the rest of the world. So it really shows that the bone metabolic problems in India are very real.
Yeah.
There's no doubt about it. And by the way, I just make the added emphasis. You showed a number of cases successfully with the intramedullary device. And I think that's really the favored technique because it's more biologically friendly than putting an intramedullary device in and an extramedullary device. And it also does a little better job of guaranteeing your alignment. So there's a lot of advantages to it, so long as you can get sufficient fixation.
Yeah. Right. Coming to the severe varus deformity, and there's several classifications. This is by far one of the more recent classifications. So in terms of balancing, let's start with you, Dan. Your go-to, the structures that you always release.
So I will start with just only talking about the varus knee and the knee that needs releases. And it's important to point out not everybody needs releases. But if you're going to do releases, the way I generally do it is I start by Working from the front, I work around the medial side of the knee, make sure that I've taken off the deep medial collateral but preserved the superficial medial collateral. I'll take off the osteophytes. I will work around to the semimembranosus and take off a little bit of the top of the semimembranosus. And then at that point, if the knee's balanced, I'm done.
Yeah.
If the knee's not balanced, I will slide down the superficial medial collateral ligament just a little. Not nearly as far as we used to do it, and particularly not in women.
Right.
And then if that doesn't do it, what I like to do is tension it with a lamina spreader and use an 18-gauge needle, and I pie crust it. And to be honest, the pie crusting for me was a game changer. I didn't think it would be that good. I thought it would be dangerous. I was worried about it. But at least in my experience, it's been a very good way to manage this sort of medium to medium severe varus knee, excuse me.
Right.
A really severe varus knee is a different game, but we'll talk about that later probably.
Yeah. Naren,
Little bit lateralizing the tibial plate.
so you
and-
do a reduction osteotomy. Mahesh?
Yeah, exactly the same reduction osteotomy, and also depends on what structures to release depending on whether it's tight in flexion or extension.
Right,
If
okay.
it's tight in extension, maybe posterior osteophyte removal and semimembranosus.
Yeah.
Tight in flexion, I would do the anterior fibers
Right.
of MCL.
Right. Rajesh, there's a lot of talk these days about not releasing soft tissues. And you use technology.
So, I think, and that is true. What we 15 years back, we would release MCL distal
So
part.
you reduce it less.
Reduced it, but it has not become zero
All right.
in our patients. I still have 15-20% of the patient where
Okay.
I will have to
Right.
some extent.
So let's go down the panel. Just your preferred alignment. Amar, at the end of a varus knee, where do you leave your knee?
So, I'll start off with a 90-degree tibia. I'll talk about the tibia.
No, your
But-
alignment. I just
Yeah.
want your alignment. Zero,
Zero.
neutral,
Zero.
valgus. Jan,
Zero, a degree or two of varus I'm ready to take.
just go down the panel.
I err on the side of little varus, never on the side of valgus.
Mahesh?
If I'm doing manual surgery, I like to get it zero. What I think I want to get zero, but technology
Okay,
2 or 3
Naren?
degrees of far.
Zeros.
Dan?
Yeah, aim for zero, but if after I've aimed for zero and I still think that I can solve the problem by avoiding a big release with a tiny bit of varus, yes, a tiny bit of varus, but
Okay.
I'd be a boundary of about 3 degrees.
Right. So these are the releases we talked about. The real issue is what you raised, Dan, pie crusting the medial collateral or medial epicondylar osteotomy. I know Arun has done a lot of work on this. There are some adverse reports of both pie crusting and medial epicondylar osteotomy 2016 and 19. These are some of the articles where you get what they call a stair-step failure at the joint line and the need for additional constraint in these type of options. This was one of Leo's works, one of his articles. Okay, we move on to the valgus knees. Our course chairman, Dr. Ranawat's fabled classification for valgus knees. So here is does anybody go away from their conventional? Do you go to a lateral approach when you're dealing with valgus knees? Anybody in the panel do a valgus exposure? Okay, nobody does that. Jayant, how do you address rotation on the femoral side?
Nowadays, I think we have the luxury of technology, so a CT scan would tell us.
No. Tell me intraoperatively, how would you do? Let's not talk about CT scans. You have the patient on the table. What landmarks do you use, and what?
So in a patient who doesn't have significant valgus,
No,
I
we're
would look at
talking
PCA, but in a valgus knee, it would be epicondylar axis and right side line. That will help me guide the rotation.
All right. And do you use anterior or posterior referencing?
So I use anterior referencing most of the time.
Okay. Does anybody do anything to the lateral popliteal nerve? Do you explore in a fixed severe valgus of 20 degrees? Amar?
No, never explore it, but we have gotten more comfortable with exploring the nerve if there is a post-operative problem.
Okay. Nandu? No, anybody in the panel? Dan? Okay. How do you assess the adequacy of your release? Dan, let's start with you. You're starting with your release. At what point of time do you know that I've done enough?
So it's a good question. And what I like to do is under-release a little bit, because most of the time on the lateral side, most of the release for me is a pie crusting technique. So what I found is if you under-release a little bit and then continue with your operation and then recheck it, oftentimes it is stretched out a little bit more. The times I've made an error is when I've forced a lot of release at the start, and then eventually you see the patient back later and you say, you know what, I overdid that release a little bit. So I think under-release a little bit and realize that it will stretch a little with time if you're using the pride cresting technique as your primary way of releasing the lateral side of the knee. That's different than a case like that, though.
Right. Now, if you have a situation where you have a valgus and a hyperextension, which is not uncommon, how do you address the deficient lateral condyle, Gautam? Typically, in a hyperextension, you distalize your distal cut.
Less cut of the distal condyle. And
you have a situation like this, how do you address that?
I'll wait, I'll see after the cuts, after the tibial cut. First, I'll do the tibial cut, and I'll believe my tibial cut to make the base for the femoral cut of the posterior, and for the distal, if required, I'll have wedges and my backup.
Rajesh, how would you address this?
I would, if there is, I'm taking hardly anything on the lateral condyle, then I would still accept it and use a primary component. But if there is a little gap, I would put a cement there and put a stem.
Okay, right. And of course, I don't think this is rocket science, severe valgus, unstable. Everybody agrees on a hinge here? Right, that's really what we did.
So, Ashok, can I just ask you a question? How do you make the decision in the older patient, whether you're going straight to a hinge or whether you're going to try to balance it with a VVC type implant?
So, great question, Dan. In most patients, we keep pretty much all our options. A knee that is as deformed as this with almost 60 degrees of valgus.
That one nobody's going to argue about. But
yeah.
what about the one that's 25 degrees and the patient's 75 years old? Do you start with a VVC and then only go to a hinge if you have to, or how do you make your decision?
So we look at the integrity of the medial collateral ligament. I think if that is intact, then we try a less constrained type of an option. If the MCL is really, really stretched and the anatomy is all over the place, then we go straight to a hinge. Yeah. In terms of flexion contracture, what routine distal cuts does the panel take, Amar?
So I think we've done a poor job of teaching this. I don't think you should cut extra bone. I mean, if it's a huge deformity, there's sometimes that's something you should consider, but it's become too routine. This is a posterior capsular problem that you need to release.
Right, yeah.
After anesthesia, most of them get corrected for some extent. And after that only I will decide my extra cut or
So
not.
how would you decide how much bone is safe for you?
Sir, up to 6 millimeter it is safer.
Does 6
But after that I will change my component to the PS.
Does 6 millimeter worry you about flexion instability? Raising the joint line?
Not much, sir.
No?
No.
Mahesh?
Yeah, anything beyond 4 to 6 millimeter, you will get mid-flexion instability than flexion
You
instability.
almost always get mid-flexion and you elevate the joint line. Looking at extra-articular deformity, I think I'm going to skip this for want of time. We've had an excellent talk on this. So again, the options of extra-articular, simultaneous or staged. And I think we have a wonderful presentation from Anup, I believe. So we're going to really sort of skip on this. So this is the criteria that we have laid out, and we published this a while ago. These were our coronal plane deformities and sagittal planes that we were able to correct with intra-articular corrections. Just some examples of these very, very difficult clinical situations that we did. We were able to restore the mechanical axis, and again some references. For the stiff knee, again, topic that I'm personally very, very fond of. We've published extensively on this in terms of getting the articulation. Just a quick comment on patelectomized patients. Dan, just your choice of implant in patelectomized patients.
Yeah, I mean, the problem with patelectomized patients historically has been the risk of flexion instability. And so I think that in paddlectomized patient, you should be thinking of an implant that provides some stability and flexion. In most cases, that's going to be a PS implant, but there's other obvious choices now with very stable medial side.
Naren,
Nothing more to add, sir.
anybody use anything other than PS? No.
Constraint inserts all the time in this.
Constraint, okay. So we have used CR for some of these. It stood the test of time. And very recently there is an article in the ACTA Orthopaedic and 2015 in CORR that CR is an option. This is Merrill Ritter's group.
Yeah, but to be fair, all these CR now, they're not CR, they're not round on flat. These are all highly conforming CRDs, so it's kind of a BS statement.
Right.
And to be honest, maybe the best answer is going to turn out to be the ultra-congruent knee
Yes.
for that type of
Medial
patient,
congruent.
to be honest with you.
Yes, yes.
Because a post doesn't really give you that much flexion stability. So maybe an ultra-congruent knee is really the best answer for those patients.
So we are out of time, but just one very interesting topic. Someone with a quadriceps deficiency, we're going to be talking only about patellar tendon. Let's just go down the panel. Your choice of graft, Amar, for a patellar tendon disruption following total knee replacement.
I mean, I would use a hamstring and do a reconstruction that way. And to be honest, I would have my brother do it, right? Like that's what he does, right? So I wouldn't even do it.
Right.
Semiti.
Semiti. Rajesh?
Same.
Semiti?
Yeah, tendon plus mesh repair is probably the best thing to do.
Naren?
Augmentation with the tendon.
I have no experience with it.
Dan?
So for acute would be primary repair with semitendinosus augmentation.
Yeah.
Chronic, we use Marlex mesh instead of allograft.
Yeah. So these are the options. Again, we published our outcomes with autografts using the quadriceps tendon and a patellar bone block. And we had reasonably good results with this. So on that, I'd like to thank the panel. It's been a great discussion that we have had. And we'd like to throw this open to the audience. So